Hello. Hello. What's up, everybody? Um, Today is gonna be pretty chill right now as I get some of this stuff set up. Let's see if Twitch and YouTube will work with me today. Today is a learning kind of day right now. I'm gonna stream out for a bit here. Thought I'd knock 2 for 1 here. If you guys want to tag along with this little journey, yeah, I am a healthcare provider, and if you have questions, you are always more than welcome to ask. I'm doing this. Hey, what's up, Bug? Welcome back. Thank you for hanging. What's up, Bug? First one into the chat. What's up, my friend? Post-op CT surgery. Partially awake, finding the ventilator. I should probably move this a little bit to the side here so people can see. Ooh, still not feeling good, man? I'm sorry to hear that. Shoot, you got like runny nose or something? Well, I'm glad that I'm here to help entertain you for a bit. Although the real world is kicking down my door right now, and I do got to get some stuff taken care of today. So the stream is going to be pretty chill as I knock some of this stuff out, since this is required stuff that I do have to do for my IRL work stuff. So yeah. Ooh. Ooh, you got like halls or something? Something like a little like lozenge or something to help kind of cool? Stuffy nose? Ooh. You taking something to help cool that down? Like, do you use a throat spray or anything, like a little numbing throat spray to help eat? I hope you're eating okay too. Ventilator. Alright, blah, 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 blah. Those are the hyperventilate the patients. 2, 3, 4. I think there's like there's no reason to do that. Probably this one. Control the bleeding. Oh, is she bleeding? Oh, Mucinex. Been eating and drinking. Good. That's good to hear. Post-operative bleeding is controlled. This can be accomplished through hypertension control, sedation, elevation. What? In addition to P. Yeah, isn't that what I did? Hold on. Sedate, transfusion, PEEP. Right? Yeah, okay. Yeah, dude, for real. Been eating and drinking. Okay, good. I'm good that you're at least getting some food in your system. Food and drink in your system help keep you going. You got Mucinex. That's kind of busting up all the mucus in your nose and all that. I hope you remember to like. What helps? I mean, it's not necessarily like a medical thing, but it does kind of help you feel a little better. Just kind of have like some nice warm water to help kind of sit on your throat. Like not like hot water, but just like some warm water to help kind of soothe the irritation in your throat. Like, take a cup of water. If you're British, boil a kettle. If you're American, heat up some water in the microwave. Just kind of drink a little bit of warm water, help kind of ease the throat. It'll kind of help It'll kind of help with the burning breathing and stuff as well. You can also take like Halls or something, like cough medicine and such, to help at least alleviate some of that stuff, man. 5 hours post-op from cardiac surgery. Vital signs include blood pressure, cardiac output of 1.7. See, drainage is 5. It's 3. Blood pressure is low. Heart rate is low. Most likely this too. Well, I might have to initiate temporary pacing. These are the main two I think of. Consider what interventions will increase cardiac output. So pacing or heart rate, stroke volume. Heart rate, stroke volume. Yeah, with adequate preload indicates myocardial stunning, requires temporary pacing. A positive ionotrope to increase your cardiac output until it recovers from myocardial stunning. Yeah. Oh, that's right. His CVP is low, so he should be okay. Despite the infusion of 1.5 isotonic fluids, blood pressure is 95/40, heart rate of 80, CVP of 8, urine output of 30, temp of 99.3, temp was 91. Rewarming, surge, and low circulating volume is my guess. Analgesic, analoxics? Yeah, immediate postoperative hypotension usually is a result of low volume. However, despite hypotension, despite fluid resuscitation, consider that's a vasodilation of warming, surge, and all that stuff. Dude, bugs, don't worry, man. It's all good. You're It's okay, man. That's all right. You know, I understand when, you know, life happens, so I stream when I can. I leave the VODs up for people to watch. If you always need something to keep your mind off something, you're always more than welcome to watch the VODs, support in any way you can. Any little bit helps. You don't always have to be there, but I know that when you do show up or, you know, throw a like or through anything, it really does help. I really do mean it. Everything you've done so far, even just coming here saying hello, even though you're sick, it does mean a lot to me. Thank you so much, man. Why is my avatar all reset? I'm gonna fix it up real quick here. There we go. Better, much easier. Your target glucose control for cabbage post-cardiac. Less than 180 usually, right? Measures. Achieve adequate pain control post-cabbage. What are the 3 measures are most important to perform? Partner with patient. No. Encouragement. No. Oh, struggling to achieve adequate pain control. Yep. 3 days of post-cardiac surgery. Has a history of type 2 diabetes with A1C admission of 9.2. He's been hyperglycemic most of the time since surgery. This morning's chest x-ray shows atelectasis. He has a new onset of AFib. Which of these assessment findings should you look for because they may indicate complications? peripheral edema. And low urine. Oh, infection. Fevers. Wait, what? Hold on. So it was a post-star check for 3 days. History of type 2 diabetes. So increased risk of fever and infection. Been hyperglycemic most of the surgery and he has a new onset of AFib. AFib can affect low cardiac output as well as respiratory insufficiency. So that would be low urine output. So it would be low urine output, low BP, and low cardiac output. It would due to AFib. Oh, fever and respiratory insufficiency. That's what I'm looking for. Not sternal wound injury. So it would be fever and respiratory insufficiency, but due to the atelectasis. So he has trouble breathing, and then he could be developing infection in his lungs. With low urine output and low BP. That's what it says. 2 days post cabbage. Respiratory rate of 22, shallow 90 on 4 liters, crackles, bilateral bases, diminished throughout. He's not in pain. They don't indicate pain, so possibly increased mobility. No, not chest tube insertion. You want it. And possibly increased diuretics. Pulmonary hygiene. No, not that. Incisional pain. That's what it would be. Yeah, because you don't normally go for diuretics. That's normally something you would not ever consider. 5 key factors to include in a patient's discharge teaching. Pain management, new pain meds, reportable conditions, activity progression, incision and wound care. Yep. Easy stuffs. Alrighty. So I have to do this assignment, so it's gonna be a minute. You're gonna have to bear with me for a bit. I might be pretty focused at this point, so I won't be talking as much going through this part. It's 200 ml bloody drainage chest tube for the past 2 hours. Packed red blood cells were given in OR. Which interventions should the nurse anticipate? But we don't even control hypertension and check coagulation status. But we haven't even identified if he has it. Which interventions should the nurse anticipate? Continue to monitor. Yeah. Well, no, not flat, because you wouldn't anticipate it. Bolus titrate map. No, that doesn't do anything. The coagulation studies would make sense, and control the hypertension would make the most sense, but it's the only thing I would make sense out of all of that. Which care intervention should a nurse use while monitoring a patient's incisions and access sites after cardiac surgery? Let's see. No, don't do any of those. Usually, which care intervention should a nurse use more? Usually, it's usually maintain the OR dressings. Random bug. The answers are 15, 83, 61. Betty has 57 hot dogs left. All right, now where's my 57? Oh, God. Fantastic. I mean, you can do prophylactic antibiotics. Incision care after cardiac surgery includes cleaning incision, saline betadine, removing or just. Okay, per possible protocol. Okay. Patient underwent cardiac surgery, which nurse should include discharge education. Cardiac rehab? No. Caring for pacing wires. Wound care. It's mainly wound care, isn't it? Yeah, wound care. Hypothermia and Yep. Cool. Cool. Nurse says patient has arrived ICU after cardiac surgery. Output is. I'm sorry, what? Oh, wait. What initial intervention do I anticipate first? Titrate vasopressors to map up 65-85. Or isotonic fluids. Let's do the fluids first. When it comes to test answers I don't know, I just pick the fanciest sounding one that has some correlation with the problem. Honestly, that is a strategy. You'd be surprised how with some of those ones they would actually just ask for that kind of stuff. You know, they would just be like, "Oh, this, and then blah 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 blah," like literally everything that says it on there. But sometimes that works. But then there are teachers who like to take it a step further and then like one up you in that regard. I've met those teachers before. They're not fun. There are 3 benefits from early mobility. Which 3 findings in a patient in the acute recovery phase? Acute recovery phase after indicate possible tamponade. Muffled sounds. Yep. No. Yep. Tolerating activity. Yeah, so far. That should be it. Hey, there it is. All right, let me just switch this over so I can get the next assignment up for us here. All right. Yeah, I hope you feel better, man. And if that sickness has been raging with you, I hope you get better. That shit's never easy.
Transcatheter aortic valve replacement or TAP.
Ooh. Okay. I don't know if that's a copyright, so I have to mute that technically. So there we go. Cool. All right. Back to work. More work stuff. Aortic valve replacement. Blah, blah, blah. Surgical AVR. So they actually go in and open it all the way up to do the valve replacement. TAVRs when they do it through the catheter to replace. Previous stroke, CAD, cabbage, permanent face. Okay. Jesus Christ, you got everything under the sun. It's TAVR, I guess? Yeah, so let's just do TAVR. Cool beans. I'm trying to speed run this work. I'd love to go back to it, read it later, but like, you know, with deadlines and stuff, there's always a pain in the butt. Yeah, it's always a pain in the butt. But I always go back for this as reference. It's super helpful, but when you got time crunches, it's like you can only take in so much. TAVR, recovering from anesthesia, vascular site, hemodynamic support. Yep, those are the main things. These are the main things. Transfemoral. That means they go through the... Let's see. That looks about right. Yep. Trying to speed run, learning how to stay alive. Vascular. Which approach to TAVR is associated with the presented potential complications? Vascular insufficiency, retroperitoneal bleeding, bleeding at the insertion site, pseudoaneurysm formation. I could, the insertion aortic site, increased pain. That I can tell that is transapical. I can tell you that much. Transaxillary. Transaortic. Huh. Transfemoral. There you go. Let's see. Moving on with life. Scheduled placement TAVR device along with a frame, which has a right bundle branch on her EKG. Which Which form of medication is following procedure? VTE. Wait. Do you anticipate for the following his TAVR procedure? Warfarin, ASA. No. Maybe his pre-op meds? Not necessarily diuretics. No, not local anesthetics, pre-op meds. Oh, probably it is analgesics and local anesthetics. So ASA, platelet, yep. So it is local anesthetic. VTE prophylaxis, analgesics. Yeah, pre-ops. So, oh, oops, I doubled up on that by accident. ASA and Y2 plate, not warfarin, because that's different. So, prophylaxis for VTE, pre-ops. That was more or less right. Just too many anti-coags. But that's the doctor's job, not my job. Urine output 0.4. 67. CVP low. Urine output. Maybe a ionotrope. Not a bolus. Well, maybe a bolus. CVP is a little low. I think it's above 5 where you would want it at. Not vasopressor. Oh, fluid bolus. I'm in CVP. Okay. Cool. Assignment time.
In this assignment,
Being treated for COPD, diabetes, psoriasis, rheumatoid arthritis, CKD. Let's see, the CKD, the diabetes, COPD. But the top 4 patient care priorities post-TAVR. Monitor sites. Yep. Provide recovery from his report hemodynamic deterioration. Yep, that should be pretty easy. Standard stuff. Retro. Okay, let's see. Cardiac tamponade is transaortic. Thoracotomy, pain, and respiratory compromise, most likely. Retroperitoneal is transfemoral. Actually, that might be a brachial plexus injury. I think that's what that is. Yep. Oh, okay. There we go. Cool. 5 post-op action should be taken for post-TAVR with a transfemoral site. Coordinate expert patients performance. From neurovascular, follow protocol. Yep. 1, 2, 3, 4, 5. That should be it. Not quite. Consider the transfer. From neurovascular, control BP, except for well, not brachial plexus because you want. I think it's yeah, okay. So it's not really chest tubes that we're looking for. Moving on with life, vascular injuries, the most frequent adverse. Anticipates. Bleeding. And vasculitis. Yep, arterial. Yep, I was right. It's like it can't be venous because venous you just kind of put pressure, but like arterial you gotta really put down pressure. Experiences hemodynamic instability in OR during TAVR, requiring epi and vasopressin. 30 minutes following the admission to the ICU. She is cool with poor distal infusion, perfusion, has BP of 86/50 with a map of 62, HR 72, low urine output, ABGs. Oh. Yes. That is not good. I mean, Obama's last name? Barack. Don't you mean Barack Obama's? Or Bayrock? Hold on. Is cold blooded perfusion, low urine output. I administer probably a fluid bolus and start phenylephrine. I want to say. Oh, right. Cardiac output. So possibly ionic tropic support? Yeah. Needs fluid bolus and a PA catheter. Yep. 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 Maybe calcium channel blockers. So prophylaxis, yes. Analgesics, yes. ASA and antiplatelet, yes. Ew. So, oh. Okay. So the last one was. No, Barack is his first. Obama is his middle. Really? Really? What is his last name? What is Barack Obama's last name? All right, exam time. Hold that thought. Patient. I know when I chance moral television which care anticipate. Monitor for retroperitoneal bleeding. Yes. Which of the following nation? Yep. Following a post-TAVR and because deployment of a TAVR device can result in pressure along. Oh. Shoot. Post-TAVR with transfemoral approach. The patient is admitted for post-TAVR with a transfemoral approach. Okay. Which findings relate to the procedure leg? That's fine. That's fine. That's fine. Patient post-TAVR is receiving ASA and cool. Done. Passed. Alrighty, another one bites the dust. Let me just refresh this real quick. Fantastico. Alright, looks like we're going away from the heart and looks like we're going back to the kidneys now for this next session is.
When kidney dysfunction progresses into failure.
Yep. Kidney function. Your kidneys are your best friend, you guys. Please, please, oh God, have mercy on your kidneys. They are your best friends. Your kidneys and your liver are your best friends. Please don't hurt them that hard. Please don't hurt them, okay? Also, Bug, what are you saying? What is his last name? What is Obama's official last name? Blood pressure 70 map. Jesus Christ! Oh wow. So CRT is when you need it for hemodynamic instability. Tell that to my drunk alcoholic neighbors. Well, you can only take the camel to the oasis. You can't force it to drink the water. You know? But I tell you now, Bug, please take good care of your body. It can really, really help you in the long run. Doesn't mean it has to consume your entire life, but, you know, just a few, like an hour a day of just some simple exercise. And it doesn't have to be like the boring ass exercise. Find something enjoyable that you love, like whether it be like rock climbing, jogging, playing soccer, I don't know, playing football or something. Just something fun that you like to do. Hell, parkour. I remember I did parkour for a while, and I was like, I thought that was fun for a little bit, but you know, there wasn't really gyms or things, any of that, like at the time to be able to do parkour because it was such a new thing. Now we have parkour gyms, and I'm like, shit, I wish I had those back when I was younger. Or trampoline gyms, dude. Trampoline gyms are fun, dude. They're awesome. The reason Miss West is accounting for CRT, blah 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 blah. Yeah. Oh man. Absolute contraindication, I'm assuming. Antibiotic therapy, I'm assuming. Lack of vascular access. Oh, really? No vascular access. Absolute. Bug. I'm inside because my neighbor kids will mess with me, so what I'll do is every time I die in a game, I do one set of 12 eights each arm. Oh, snap. Go for it. Get that challenge, son. Get that challenge. You know what? Good, dude. Good on you to keep up the weights. Much respect to you, my dude. Much respect. Mrs. West is in a precarious and stable situation. Yep, it will help. This will help. Oh shoot. Oh no. Oh no. Playing World at War on veteran mode? Dude, I can't imagine trying to play World at War and then every time you die, you fucking have to do curls. Dude, that sucks. But that's fun though. That sounds like a dope challenge. Yep. I think I'll learn more about this later on. This isn't. Are the dialysate fluid rate appropriately given? Nice. Very nice. There we go. Okay. The order is for... I think, what is it again? It should be like... That's fine. Looks okay. Okay. Placement solution is required due to the large volume of fluid removed from the intravascular space via ultrafiltration in the CRRT circuit. Can run into the circuit before the filter, pre-filter, after filter. What? Pre-filter then. Nice. Dang, this is a long one. Wait, what? Has received CRT provided his order for 50 an hour. Yes. I only took out like 40. So, wait, what? Is receiving R to provider has ordered fluid removal and blah blah. That's at 40, right? No? 50? For the next RCR tissue set to remove 40 plus the additional 50 ordered for a total of 90. So total intake minus output is 40, then plus the additional. Oh, my bad. Okay. This is stuff like way in depth that you guys would not be able to understand, but just it's a lot. Wait, what? In order to maintain patency and blood flow through the CRT circuit, anticoagulants is often used, and this is appropriate. Got it. So she is. Damn, that sucks. This is nuts, my brain. Top 3 priorities, monitoring. Assess the dialysis process, assess the circuit, and the hemodynamics. Yep, that's correcto mundo. Halt the procedure, no? Usually in first rule of like anything, sometimes if it's not working, then you just stop it. Very rarely do you just continue doing the procedure, but it's really... Wait, what? Patient's pulmonary status deteriorating, have increased respiratory stress. CRT 6 hour ago, hyperkalemia, we were... Mm-hmm. Sorry, there's like a lot of things going on in my head, like when it comes to answering some of these questions and such. So if something does, if you genuinely have a question about health or anything like that, just let me know and I'll try to do my best to answer it. Because a lot of the stuff that I'm showing here is more related to medical professionals. So a lot of it is some of it can just be information overloading. So yeah. What is the best action to take? Is there additional potassium to replace them? Wait, what is happening? What happened to her? EKG shows PVC's inverted three-way. She remains lethargic. What's 7 point? Whoa! Now it's all whacked. Yeah, she's got instability now due to the cardiac. Potassiomis. Alright, that's all 3 sections of that one.
You provided excellent nursing care to Ms.
Cool.
West.
All patients' profiles bloods are suffering from volume overload, unresponsive to diuretic therapy, which 2 patients' profiles anticipate to have CRT order for ultrafiltration to remove fluid. Huh. Let's see. I mean, he looks fine. Let's go with the 2. This one looks pretty bad, and this one looks pretty bad too. Yep. 64-year-old man with hemorrhagic pancreatitis. He's also hypocalcemic. Provided order CRT. Something that increases calcium levels while maintaining potassium. So, like, this looks pretty good. Yeah, that looks right. Increases proof solute. Okay. What? Okay. So 75. This is maths now. I gotta do maths. Wait, try. Okay, math times 75, 50, 125, 175 minus 5, 170, 170 minus 150, 150 minus. No, 150. So they want to remove. So one removed. Should be 175 on that one. Then 80 by subsequent line. Yep, there we go. See, that first one was like a lot of like maths, but I can do maths. Please learn to do maths. Maths is important. Patient with CKD managing kidney failure with peritonitis. Rhabdo. Test 6.4, pH is 7. What the yikes. I think it's post filter, right? So it's pre. Patient with hyperkalemia and acidosis needs low potassium, which is why we set up in the replacement food to pull potassium into the filtrate. Alkaline base distillate to crack light. Diffusion. Okay, I see. Man. Multi-system trauma patient. Okay, due to rhabdo is receiving NOR. Phenyl for pain control. So on the enteral feeds and not able to receive heparin due to increased bleeding risk. 3 ounces proline filter life. Pre-filter solution, citrate, or other anticoagulants. So the flow rate won't help either. So, okay, hold on. Fix this, fix this, fix that. Yep, I know that already. Next. So you want a low potassium pre-filter. And then this one you want posts. You want to consider any other anticoagulants. Got it. All right. Exam times. Got that, got that. Oh, crap. Okay, fluid. He had 80 minus 60, 20 plus 40, 60, remove 5, 10. Wait, what? What? Wait, 80, 60. Damn it. Okay, hold on a second. I'll come back to that. A nurse is infusing a citrate for anticoag into the pre-filter size. I think, yeah. Cool. Hold on, I'm gonna take a look at the scorecard real quick. Set if the fluid is can now put plus the fluid ordered removed. So if it was 80, 60 to 20, 20 plus 20 plus 4, 60 minus 50. Wait, what? Hold on. $80 plus 80 minus 60, that's 20 plus 40, 60 minus 50. So it should have been something else. Okay, whatever. God, I gotta double check my numbers here next time. All right, another module down. Thank God. All right, hang tight. Okay. Goodness gracious me. I hope you guys are having a good one. I hope you're relaxing, Bug. I hope this is just chilling you out for a bit, because I know it can be stressful at times in life. Life is stressful, it is. And I hope that I, as a VTuber here, can help alleviate, help you relax,
CRRT
and
is a
chill
life-saving
out.
therapy for
Dang
medication.
it! You're interrupting me. I hope you get to relax a little bit with this. Okay, this one doesn't seem that bad. Thank goodness. Alrighty, back into it we go. Okay. Okay. Sorry, I got a little distracted by something here, but we're okay. Blah blah blah. Yes, I understand. Scuff. Man, this is like a whole course in of itself that I have no time to be able to cover so quickly, considering I just need to get the basics down right now. Jeez. That sucks. Show filter for something that's 6 hours. Yep. Damn. Damn, this is okay. Long list final stance pulse checks. Yep, I was right. Wait, what? Rest -1. Map 62, level fed, lactic acid elevated, creatinine. Mm-hmm. Jesus. Alright, cool. So I'll check some hysteria. Not quite. Change the roommate to 0. Do not count. Oh, I see. So do not count, and then set the removal rate to 0. Yeah. If she's got fluid coming out of her system, gotta get it out. If it's too much. Jeez. Whew, boy,
In
oh,
all its permutations,
oh,
including
goodness.
scuff, CV.
Moving on. Neurological. Cool. Wait, is Kraken Longles? Blood pressure is shit. Heart rate's elevated. The pressure. Kingston. Clogging? No. Got it. Patient's on a ventilator. Man. Sorry, I'm a little silent on this one, but it's like, it's focus time. It's like very, very focused time. I should be almost done here. No. Alright, let's see what this citrate infused pre-filter side calcium levels routinely monitor, which is cool. Uh-oh. There's preparing to initiate vasopressor therapy, undergo CRT, blood pressure. Consider volume deficit prior to. Dark. Maroon streaks. No, that's. I think that's it. Wait, what? Is it in darker streaks? Filter pressure is at 150 greater than what was initially. Sepsis with the patient receiving. Okay. Okay, gonna need the scorecard on this one. Alright, I gotta get some serious stuff here. I will be right back. I gotta take care of this intense quiz here. Be right back. Alright, guys, I'm sorry about that. I had to take care of that business and stay really focused on that. So, looks like we're good. We're okay for now. So this is done. Goodness. So many modules, so many to keep going off. Oh, goodness. Oh, excuse me. Woohoo! When you speedrun trying to take care of people. Goodness. It's never fun. It's one of those things where life hits ya even harder than usual. Why did I change my accent all of a sudden now? Oh, this is important, huh? Ooh.
Patient is a 42-year-old.
Oh boy, oh boy, oh boy. Sights and all them sounds, huh? There we go. Okay. Let's get through this here, shall we? This one looks like a long one. 42 woman. Found her unconscious at body locks codone. Yikes. Do. Isn't that what I just said? Suspected aspiration, ineffective. Or is it just these three? Ability to protect her airway, not ventilating, and appears to have aspirated. Oh, so it's these three, not this airway trauma. Oh, she ripped that shit out. Yikes. Yikes. Oh yeah, prepare for immediate intubation. Yep. Yep. Those are the main three, usually. Ativan and ABGs are usually... ABGs are not that necessary. Airway, breathing, circulation, your ABCs. Gotta remember your ABCs. Vitals, cardiac rhythm for physiological assessing pain, verify ventilators. Wait, did I not? Post intubation includes reassuring. They're knocked out. Okay. Everything else was right, but I just yeah. I have to reassure them. Yeah, it's just the reassurance. I don't think about it because usually they're usually knocked out, but yeah, it's important to do that. Oh wait, oops! I probably should have checked that. She is. Oh gosh. Oh. Oh shit. She's at -4? Shit. FiO2 of 1.0. Okay, I guess. The fact that her sedation is screwed. What? Wait, what? Wait, what is she at? Currently 4, deep sedation. Damn. So then she's good on that. What else am I missing here? CO2 of 30, that's fine. 102, 24. So ABGs are fine. What am I missing here? It's definitely in here. Yeah. Boop, 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 boop. obstructive sleep apnea. It's the only other thing. Yeah, isn't that what I say? Was unable to wean due to hypercarbia. Training comes to place when intubate will require long-term ventilation. There's wait, wasn't that what I just said? Isn't that what it was? Isn't that hypercarb? Oh, hypercarb and okay, so hypercarb and OSA. Doy. That's usually why, because you don't do it. Tracheostomies are scary as shit. And when, especially post-surgery, you're just like, holy fuck. Cannulation plug is used. Considering that the plug is placed over the trios. Yep. Okay, so I was right. Huh. Okay, I'll take it. Sparing mucus plugging accessible. No, you do not irrigate the saline. That is... Yikes. Why would you ever just throw water or salt water into your lungs? That just sounds like a bad idea. Yes, ventilators, ventilators, ventilators. I don't know. Cool. YouTube videos like on before this I even watched this has like a really good. I'm pretty sure I had this right earlier. No? AC initiates breaths. Oh, assistive control. Duh. Control. Yeah. VCAC. I usually know VCAC. It's a little different. It's Yeah. Yeah, successfully weaned FIO 2.4. It's in 0.4, 500 SIMBA. 48, so he's still above. So maybe PSV, pressure support volume? Yeah. Mm. See, it's always weird to like remember the names with some of the stuff. It's just like because the names change over time, and like so, some of them are pretty consistent, but some of them are not. Just because like sometimes acronyms have different names. What? Yep. Like I know what they mean. Sometimes I just forget the terms. You know. It's just, it's like. I understand that it's like one of those things where you try to remember the formalities, but then you at the same time, it's like you don't need the formality. You just need to know what the concept means. Patient. Apnea. Yep, there we go. There we go. Yep. Easy. Oh, I've been dealing with all of these the entire time. Oh. Did I really forget that? There we go. Cool. Getting
As
through.
he cared for Ms. Abram, an endo.
Yep. COPD with pneumonia, currently on a non-rebreather. She's febrile. I anticipate a bronch? No, not necessarily. You can do a BiPAP. BiPAP? Because you don't need to intubate per se. Well, maybe you do need to. Either a bronch. I almost would say bronch. But yeah, you know, fine. If we're gonna do the secretions and clear it out, you could do an ET tube and then also bronch them at the same time while you're there. Yep. Reassure. Yep. Reposition tube. Wait, what? Match the nursing action to the complication as intended. Displacement. Oh, that would be this one. Pressure ulcer keep. No. Sorry, I had to think about that for a split second. My brain was just like, whoo. Assuming tracheostomy following a laryngectomy yesterday. He was to be weaned after surgery. Which three nursing priorities are required for her safety? Yep. Jesus. Respiratory distress and cannot protect the airway. So would it be respiratory failure and inability to protect? Yeah. Okay. I don't know why that was so difficult. Sarah evidence is on a mechanical ventilator. What are your three nursing priorities? Those are my main priorities. Low minute volume ventilator. Assess the patient. Assess the ventilator circuit and reconnect if needed. That's what you need to do. High pressure. Not low pressure. High pressure. High pressure. Okay, exam time. Oh boy, here we go. Gotta do this right. Gotta do this right. Patient observed trauma is lethargic. PaO2 of 57. Presence of which other factor should they do? No. Impaired ability to swallow. Because then he could choke. Which is not protecting the airway. Should indicate immediately after the patient. Which intervention is indicated immediately after the patient is intubated emergently? Vital signs, usually. Yep. Nope. Nope. Yeah, that's what you need. Shoot. I forget this one already. It's PaO2 pressure supported. I think it's pretty sure it's pressure supported. Hey, what's up, Drew? You didn't like Dune? I haven't seen it yet. Ooh. 2 hours wasted, huh? I heard it's based on books, so I don't know. So pressure control. It should be pressure control. Who has an ET2? Is it mainly because you saw? Was it because there was a lot of action sequences, or what was so bad about it? Oh, so kind of. Wow. So it wasn't as actiony as you would have hoped for. Oh, did they? I've never read the books, but I don't know much about Dune or in the whole. I know that it was a book, and that was about it. A book series. Well, I mean, maybe they're doing the Avengers effect, where it's like you play, you gotta watch the second half. No, nothing in the end. I have to wait like 1 year or two for Dune 2. Well, maybe I'll hold off on watching it then until both movies come out. Until the second one comes out. Then I'll be like, okay, is it a good movie or a bad movie? Was it, do you have to like, is it like, I'm assuming it's probably a lot of lore building, you know? That's my guess, is that it's not like turn off your brain action fun. It's kind of like lore building, almost like you think of something like Lord of the Rings kind of thing. Pressure ventilation delivers gas at a variable pressure based on compliance. Volume ventilation delivers gas at a preset vital. I think it's pressure. No, volume ventilation modes. Oh. Oof. Okay. It's one theme. Then another fight scene was just slash slash slash. It's one theme each scene. Like one scene talkie talkie. Yikes. Alright, hold that thought. Alright, hold that thought. I will be right back. I gotta go. I gotta get serious here for a second here, so be right back. Sorry about that. I had to get a little serious there for a second. This is related to some IRL stuff right now. Anyway, Drew, going back to what you were saying, the next scene, explosion, boom, everywhere, bang, boom. I mean, yeah, I can imagine. Like, I don't know much about the Dune series at all, honestly. It's never. It's a book I haven't read, and like it wasn't even really on my radar for a very long time. I know that it was advertised, and I just saw. I was like, that looks interesting. Sci-fi kind of deserty-esque scenario looked really interesting. I didn't think too much about it. You know, it was okay. So would you say it's definitely not worth watching, or is it worth watching at all? Hmm? What do you think, Drew? Oh god. Oh wait. How long does this one? Oh damn, this is a long one. Okay. Spontaneous awakening trials. Yeah. That's patient. Yep. Do 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 do. Wait, what? Okay. Do, 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 do. Just calm and regular, able to respond. Okay. Continuous condition to hypoxia due to ventilator disconnection, preventing falls. Which four nursing actions help prevent complications? Yep. 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 Yep, 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 yep. That's all part of it. Train of four. This is important. So monitoring a peripheral nervous system is used to assess the level of NBA by identifying how much a patient's muscle response after stimulation applied to the facial or ulnar nerve. This will be used in conjunction with clinical assessments. Serotonin gets 100%. This is a sign of pictures. Okay. Ah, okay. Damn, this is nuts. Okay. Literally got... Okay, there's literally only one trial after that one, so I'm burning through these pretty quickly. Vents are not fun, people. If you have to shove a tube down your throat, then that's not a good time, ever. Trust me, it's not a good time. Just means you're in a shitter. You're in the shitter right now. Big boy brain stuffs. Ooh. Sorry if this seems a little boring right now, but honestly, like, this stuff I'm just trying to burn through as quickly as I can. It is important to know this stuff, but I tend to soak this up. Wait, what? Okay, based on ventilation estimate, where is she at? NIP. Okay. It's not too bad. Yeah, she's in a good spot. Weaning practices. That is the calmest vent patient I've ever seen. There we go. Answered. Electrolytes are important too. Safety screen is important. Not necessarily the sleep pattern. Don't really need the family present for support, but you just want to check the other stuff, you know. Boop, 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 boop. Boop, boop. No. PPE. Suction equipment, yes. Non-invasive delivery. Oh, scissors. Scissors. Is that the other one that we're missing? Scissors. What's this? Why is it specifically scissors? What? No. Yep, those are all correct. That's kind of straightforward. Oh, that's not good. Wait, what did I just say? Yikes. CO2s are okay. O2's going down. Bicarb's still okay. SiO2's not too good. Yikes. Okay. Yeah, that was the only concern that I have. Decannulations. One, two, three, four, five, six. I don't think it's gonna be hemostats this time, is it? Yeah, still the same equipment. Damn. Okay, he looks fine. Cool. All right, assignment conclusion.
You coordinated.
So patient has VMT rate of 12 on 80, 375, 7.5. So 1, really. SpO2 is super. Sedation, probably some of this. Yeah, that's probably all. Wait. Samurai. It's time for the safety screen, the SAT. Do they still do SATs in school? Actually, that was a good question. I have not been in main school for a while. They're still doing SATs? Is that a thing still? I know with COVID, I think they stopped it temporarily. SpO2 86.6. C pots. Yeah, I see raspberry. No. No, do not do any of those things because he is not. He is in a bad spot. He already failed. Agitated 2. CPO 1's less, more or less. Or 2 or less, so that's good. 102 ventilators, alarming. High inspiratory. Incorrect patients feel as they exhibit signs of anxiety, pain, or respiratory gradient. SpO2 is also 80. Oh, I have to titrate it up, don't I? So then the answer would be reinitiate and then stop? Oh yeah, so it would be the stop because he failed technically. She's on CPAP of 5, 102, 85, which was SBT. Her SBT is expected to titrate. She is tiring, but SBT needs to continue to strengthen her. No. I mean, I mean, she's not holding. Yeah, she failed. I was like, how what am I thinking? She failed. She can't breathe. No, that will fucking fuck somebody's lung up. No, use lower. Use auto peep. No. Use lower VTs. Yeah. Okay, so PPWs, blah blah blah. He is not ready, so that's not an ABG issue. I don't remember what this is. NIP, I guess? His volume looks good. And I don't even know what his VC13 even means again. I completely forgot what that meant. I don't even know if I read that half the time. CPAP 5 centimeters during SPT, HERB 5 action essential to stop. Monitor patient closely, secretions, analgesia, evaluate work of breathing. Yep. The 1, 2, 3, 4, 5. Oh, wait. Oh. I mean, you don't limit the visitors technically, so yep. Cool. In addition to. Vital capacity. Wait, so incorrect. PSV allows for patient to breathe spontaneously with the pressure set to achieve. Oh. Okay, hold on.
You
What?
coordinate.
Okay. What the heck was that? That was not right. Okay. Oh no. Get the bed out of patient out of bed. Hell no. Hell am I thinking? He's knocked out and you Okay. She failed. That's what I remember. Yep, that's right. Those are all right. It's the last one. So check if it's sufficient and consistent and vital capacity. What? So it's not that, so it has to be this? Okay. So then it would be... Oh, shoot. Come on.
You
Just get me to the end, Garrett. What is happening? Wait, hold on. It didn't even let me get to the end one. Okay, I probably have to fix it, so I have to like make sure I answer it correctly and then allow me to go any further. So is the consistency in the VT. No vital capacity. Okay. Good to know. All right, exam time. Goodness gracious. Oh, my brain. Which assessment should prompt the nurse to restart sedation at half and titrate to goal? No. Oxygenation, no. MAP below 80, no. Respiratory rate, yep. It's the only thing that comes out. Patient on mech vent and SAT is in progress. 3687. Stop SAT and restart sedation at the pretrial rate. Yep. SAT safety screen begins. SAT propofol been off for 30 minutes. Pain is CPO2 is 2.8 and fentanyl is at 50. Agitation is at 3. Very agitated. Oh, goodness gracious me. Using Nocoron, another. Two and no. ARDS. That's what I remember. Which intervention prevents blood complications of patient experiencing neuromuscular? Which intervention prevents complications? Monitor sedation? No. Choose therapy? No. Ensure VT. Oh, VTE. So it is the VTE. PPV is acute respiratory distress syndrome. ARDS. Decrease. Some decrease the P. Blood tinged. Okay. Oh, mechanical. Which signs symptoms should stop SBT? PIP, SPO290. No, you don't necessarily stop that. Oh yeah, 100% if they become confused. Has been on mechanical ventilation for 2 days, which indicates readiness to wean. I forget. I think is it a VC or I think it's rapid. Yeah, it's rapid shallow, wasn't it? So, been on mechanical ventilation 2 days after SBT, RR7. Still pretty sedated. Just try elevating the head. I mean, you can ask RT to increase the FI. I don't really want to increase the FI2. I guess you can do that. Patient continue trial and oxygen saturation. Oh, greater than 88. So yeah, that's what. Wait, what? Glottis fully open. So trauma. So the glottis is fully open at end inspiration. So trauma and laryngospasm are minimized. Oh, okay. So what the hell? I don't remember any of this stuff on the thing. Which 3 assessments indicate he's ready for weaning? Weaning parameters include that a patient is likely to succeed R and R less than 30 with VC greater than 10. VT needs to be at least greater than 5. At least negative 20. So. Whoa, this one's really kicking my ass right now. Hold on. So, SpO2 falling below 80H. Yes, yes. Which should observe for which 3 indications that patient is not tolerating weaning from short-term ventilation? SpO2, respiratory 40, and decreasing. Oh, it's because the 33 doesn't count. Yeah. Okay, that was shit. Okay, I can pull up the scorecard here real quick. All right, return to the exam. Gotta try again. I'll be right back, my friends. Be right back. Alrighty then. Shit, that took a minute. Oh god, that sucked. Alrighty. That was a lot. That was a lot. I've completed a lot today. How many more do I have to complete of these babies? 1, 2, 3. 6, 7, 8, 9. Oh man, I have so many more of these to still bang out. It's ridiculous. But it's been a 2-hour stream, so I gotta call it. I gotta do some more adulting stuff. I'm probably gonna play some games tonight. Anyways, I'm gonna wrap up here. To Drew and of course Bug, you guys have always been good friends on these streams. Thank you guys for always coming in. I hope you enjoy just hanging out with me, even though it wasn't as bombastic as it normally would be. But don't worry, I'll be back probably later again tonight. So that's it. Thank you guys so much for watching, and I'll see you guys in the next one. All right.